Okay, are we ready? Are we being recorded now?
Yes.
Yes.
Okay, I'd like to call the meeting to order for the Board of Commissioners for Whidbey Health. Basically, make sure everybody knows that we're being recorded. I don't know how we're going to do the public comments, Jake.
We'll have a general public comment period. If you would like to make a comment, please raise your hand through the Zoom function, and we will unmute you.
Okay, and we'll do that on the third item. I just wanted to jump to that for a minute, but everything is being recorded. So if anybody does want to make a comment or question, make sure you state your name, clearly and where you're from. Okay, at this time, move into consent agenda.
Move approval of consent agenda.
Second.
Any discussion? All in favor, say aye.
Aye.
So moved. Is there any points of order? Any changes to anything? None. So we can go into the public comment at this time. If you see anybody up there, Jake?
Oh, there is one. We noted that there's
one attendee with their hand raised, Celia. I'm going to unmute her now.
Thank you.
Is she asking a question?
I believe she has a comment to make. Ms. Sanchez, you are currently muted. If you can unmute yourself. There we go.
Sorry about that. This is Celia, and my comment is I'm present here in representation of the union, USCW 21. I am the new union rep for Whidbey, and so I just wanted to show my presence and then also just be part of the meeting and show my support to the members. Thank you for your time.
Do you have any questions or comments before we move on?
Not at the moment. I just like to participate.
Okay. Well, at this time, we want to move into our, what's that?
Oh, I just said thank you.
Thank you. Move into our community health and safety report. We've asked Dr. Pereira and Dr. Miller to give a little brief on the COVID, the vaccines, and those things going on. Is Dr. Miller, are you on there?
Dr. Miller is on vacation, unbeknownst to me, and won't be able to attend.
Okay, well, Dr. Pereira, it's up to you.
Well, thanks. It's good to be here. It's been a while since I've seen the board, and it's good to see all of you. I was asked to come here today to talk a little bit about our current COVID situation and its seriousness in Island County in Western Washington. We're seeing a lot more COVID now than, frankly, I've seen during the entire pandemic. We've had a big resurgence in cases and a resurgence in deaths as well. In Island County particularly, and this is today's data, I looked this up this morning, we're seeing 1,000% more COVID than we were seeing in early July, 10 times the numbers. This quote-unquote fourth wave is the biggest we've seen for Island County. That's not true for Western Washington as a whole, but for Island County, our peak right now is higher than any other peak of diagnoses that we've seen so far in this pandemic. Western Washington as a whole, and this is true throughout the country, I've heard many kind of horrifying stories, but Western Washington as a whole, hospitals are at or past capacity, which means that like other emergency departments, we are boarding patients in need of admission and specialty care. And I mean, it's horrifying. Can you imagine coming to the emergency department, being told, you're having a heart attack and we need to get you to a cardiologist. And we've had people wait 1, 2, and 3 days in the emergency department because Everett, Bellingham, the main hospitals in Seattle just say, we can't help you. We don't have any room. We're boarding 30 of our own patients in the emergency department too. It's gotten to a point where Western Washington actually has a centralized transport center to sort of decompress hospitals, and they've gotten to the point when we call them, they also say we just can't help you. The resurgence in COVID that we're seeing is probably due to a combination of the Delta variant, which is much more contagious person to person, as well as a decrease in social distancing and masking. Thankfully, here in Island County, most of our older residents who are at the highest risk of severe COVID and death are vaccinated. But what we're seeing is that most of our current cases are in the unvaccinated, which tends to be younger people, but still some older folks as well. Nationwide, 97% of all current COVID hospitalizations are in the unvaccinated, which, if nothing else, I think is telling evidence of the vaccine's efficacy and that it really works to do what it was meant to do. As of today in Island County, 55% of people age 12 and older are fully vaccinated, which of course means 45% of people who could be vaccinated in Island County have chosen not to be. This is well below the statewide average and is putting our county in particular at risk for increased cases and hospitalizations. There's a lot of misinformation out there. I know you all know that, both about COVID, the disease, and the vaccinations. I urge you to get your information not from random websites or social media. Get it from the CDC, get it from the Washington Department of Health. Whatever you've heard, I can tell you personally that since the vaccines were released, I've seen zero serious side effects from the vaccines. Yes, you see people with a day's worth of flu-like symptoms. They all get better. You see some people passing out from what are called vasovagal reactions. Nothing serious, nothing that gets people hospitalized, nothing that lasts more than a day or two. But since the vaccines come out, I've diagnosed a lot of COVID, and I've seen some deaths, and I've seen some hospitalizations. That personal experience of mine is not surprising if you actually look at the numbers. The rate of diseases associated with the COVID vaccine is 0.0018%. And that, when I say that, it's very important to note that I use the word associations. These are not caused by the vaccine. And I would use the example is if you gave 350 million Americans a shot of saline, which does absolutely nothing, and then watched them for 2 weeks, 4 weeks, 6 weeks, medical stuff will happen to them. Some of them will die. It has nothing to do, it is not caused by the saline injection. A lot of the things that we've associated with the vaccinations are in that same group, and you can see that number, and I'll say it again, the 0.0018% is so low that, frankly, most of it's probably random chance. But in the U.S. to date, 36 million people have been diagnosed with COVID, and 615,778 have died, which is a 1.76% rate of death in Americans diagnosed with COVID in this country. So worst case scenario, the vaccines are 1,000 times less dangerous than getting COVID.
Yeah, and I appreciate the fact in talking to you early on that you really dove into the makeup of the vaccine. Mm-hmm. As far as trying to figure out what kind of effects they could have. So like I said, people are watching too many politics get involved in this, and you got to bring it down to the medical part of it, and the fact that the vaccine works. You can still get COVID, but not as severe. Right. And the one, like the article in the Seattle Times that I was reading and talking about was the fact of the what's it called, the long haul, or right. And there's still folks I know, nurses who got COVID in the first wave who are still dealing with it. Right. I mean, this is a month, a year and a half later almost. Yeah. So like I said, when you weigh it out right now and you take a look at it, the long-term effects from COVID, if you survive it, there's some really bad long-term effects. And right now, the long-term effects from the vaccine, and I know we're not 5-10 years into the vaccine, but the initial thing, there's so much promise with it that it's not what people thought. I mean, Well, the nice thing about an RNA vaccine is, by its nature, RNA only lasts in the body minutes to hours, and then it's degraded, it goes away, and that's by design or what have you, because your body has to be able to turn on and off the ability to make
proteins at a moment's notice, and you don't want the RNA sticking around and still making proteins that now you don't need anymore. I was actually reminded, so in my college days, I actually have 2 published papers on RNA, so this has been a little bit of a reminder of that, since I haven't really delved into that much in the last 20 years. Anyway, when the first of us were vaccinated, I can see how people were, hesitant to take the vaccine. This was a new vaccine. Has it been tested? And the truth of the matter is, even when the first of us were vaccinated, it had been very well tested. At this point, with 353 million doses given in the U.S. To date, we know it's safe. We know it's safe. And anything you hear on a random website otherwise is just false. And those falsehoods are hurting people. As of about a week ago, it's estimated that the vaccines have saved 275,000 lives in the U.S. And each time someone chooses not to get vaccinated, we're losing a chance to save another. So I ask you, if you haven't been vaccinated, it's time. Pull up your sleeve. It's the right thing to do for you. But most of all, it's the right thing to do for our community. Don't do it because you're forced to. Just do it because it's the right thing to do, just like putting on your seatbelt.
Yeah, the whole thing of being out there being forced, now people are pushing back.
Right.
And they got to overcome that. They got to get back to the fact that this is medically sound, and it's the right thing to do for our community. I know there's a lot of pushback even within the hospital, that hospitals across the nation require all employees to be vaccinated. That's coming, that in order to be in the thing. And it's the right way. I mean, we have to protect everybody. People have to get over the fact of switching from one news channel to the next. You get so confused.
Are we kicked out of our Zoom meeting?
Oh. Hey, Melanie?
Melanie, are we still in the meeting?
No.
Yes, you are.
We can't see you though.
We can't see.
Okay, it says it's connecting. Okay, we'll keep on talking and.
right.
Is that Mr. Tellis? Is that Mr. Tellis on the hook there?
Yeah.
Yeah, there are some things on the counter here that were for you, but they seem to have disappeared.
They look like lovely donuts. Thank you. It is a pleasure to have Dr. Pereira talk about this. And Dr. Scheit, and I know Dr. Miller, all of the physicians are in unique, would say the same thing. So that is amazing. I think that the vaccine is safe. The vaccine is really required, and it's as you have said and Dr. Pereira said, do it for your community. Do it for your community.
Yeah, get the politics out of it and stick to the medical side of it.
I don't see your picture.
Yeah, I'm happy to answer any questions anyone has, and I'm happy to be able to present this to the board and everyone listening.
Anybody, you guys have any questions for Dr. Pereira?
I don't have any questions. I want to thank you, Nick, for doing this, but maybe we should put something on the website. Maybe a statement from a summary of what you just told us or something like that so that people can.
Yeah, and Connor is working, he'll be working with Dr. Pereira and with Aaron. We're also trying to come up with a small little flyer that can go out all over the place that just basically, here's the ins and outs. I mean, this is why you should get the vaccine, and this is the long-term effect if you get corona. I mean, it's some nasty stuff happening to people out there. So, they need to understand what the long-term effect can be. Because a lot of people are like, well, I'll survive it. Well, will you? I mean, you may survive it to a point, but yeah.
I do have one question, Dr. Pereira, and that is there any data that shows what age group has been most resistant to getting the vaccine?
I'm sure there is that data, but I don't know it off the top of my head, but I would presume it would be, 20-somethings, 30-somethings.
Because that's the largest percentage of patients who are now getting COVID.
Correct. Yeah, it's interesting. It's always a little surprising when you see, when I see a patient who's, say, in their mid-30s who's sick enough to get admitted. Because we didn't see that in the beginning of the pandemic, which just, I think, is added information about how much higher the numbers are right now, and probably how much more contagious the Delta variant is. And, Delta kind of reared its head at the same time that we stopped social distancing measures. And so, people started their summer get-togethers again. And I think that's great. It would have been nice if that number of 55% of people in this county being vaccinated was a lot higher, because then it would be a lot safer. I think, the youngest patient I've seen with COVID was, I can't say an exact age because of HIPAA, but under a year old. The youngest person I've admitted to an ICU was in their mid-teens. And that person is still in the ICU and has been there for 3 or 4 weeks.
We just had a young lady from Oak Harbor who was under 40 that got it, and we lost her. But that's down in Texas. It wasn't local, but she's from here. And so you're starting to know more and more people that it's hitting them hard and at a younger age.
Is there any statistics on vaccinated people getting the COVID?
So it depends on which shot you get. The Johnson & Johnson, we do see more breakthroughs with Johnson & Johnson, which is the one shot. The Pfizer and the Moderna have less than a 10% failure rate.
They may get it, but they also may not get as sick. In the clinics, I will get a lot of those patients calling, but they've been vaccinated, but they necessarily don't need to go to the emergency room. They maybe have cold-like symptoms, so they probably aren't getting hospitalized as much. So that's the other part, is like you could get sick, but you hopefully won't end up in the hospital, which is what we're trying to also prevent. I'd like to also reiterate that by getting your vaccine, you're also helping out our healthcare community, who's not just us locally, but throughout the country, is in the verge of burnout from this. Just ICUs that are overworked, nurses, we can't get enough nurses, and people are retiring and deciding to get out of this profession because of it. So not only are you keeping people in this profession to take care of you long-term by doing this, that's also part of the community part. There is no cure for a virus. Your body is the only way to cure it, and this helps your body to cure it if you get it. No treatment for it. Ivermectin and all these things I get calls on do not work. They are not, there is no treatment. We don't see smallpox anymore because of vaccines. This is very similar. Please get vaccinated.
We're working on reconnecting our video connection, so just give us a minute, and we might, in the process, disconnect our audio. So if that happens, we will get that reconnected. If I may just throw in my own 2 cents here on this, what Dr. Scheidt said too. I know there's a lot of people, especially there's a sense of people feeling forced to get vaccinated, or it's my personal choice, and it certainly is, and we understand that. I think the complicating factor at this point is the fact that hospitals are so busy right now and full of non-COVID patients. We were full before this fourth wave started, and so we're already at capacity, throughout the sound, and this is just going to exacerbate. If you have to be admitted, then it's just adding to the.
This is Nancy. I think another way to look at it, and I'm pro-vaccination, I want to say that up front, is that how would your community, your family, your loved ones handle things if you ended up with COVID, especially if you had not had a vaccination? sometimes we don't think of others as much as we think of ourselves. And I think it's important to think of the impact it would have on everyone if you as a person ended up with COVID. And then the other side of the coin is, what are you going to do so that you don't end up with COVID?
And spreading it to all your family members and everybody else. I think it's real similar to like polio, because look at how long we've worked at trying to eradicate polio, and you still have some holdout countries, and they're still fighting it. I mean, where we've been successful at is where we've totally vaccinated for polio. And, you know, we don't want to be doing COVID 20 years from now like we still are with polio.
I don't want to be doing COVID 2 months from now.
I know, but like I said, you know, it's an ongoing battle with people resisting the polio, which has been a proven thing that it works. We have that opportunity now, and I hate to see, like you said, why keep it going for 2 months or 10 years, or whatever? Let's get it over with and, you know, eradicate it.
Eric Anderson here. My thoughts are on it. Sometimes these numbers are large. I don't know that we can really relate to them. I did try to make it a human situation, and I said 615,000 people have died because of this disease, and if we get them all a coffin that's 6 feet long, that is a line of coffins that reaches 698 miles. I think you're in San Francisco, if I'm not mistaken, or further than that.
Yeah, line them down.
Lining the freeway for that many hours, and it's just like crazy. I mean, that's how many people have died from this disease. So,
In our country.
in our country alone, right? Yep. Big number, huge.
Commissioners, this is Erin Woolley, and I did also want to mention that there is an operational aspect of this that I think our community should also consider. And Dr. Pereira kind of touched on it too, but as case rates rise, as more and more people are being hospitalized or coming to the emergency room with COVID, that leaves a lot less room for people that need care that don't have COVID. And it means that the organization here in this community will likely have to consider scaling back on elective surgeries. That means scaling back on people that are having their diagnostic colonoscopies and endoscopies and cancer screenings and mammography and things like that. We will have to scale back so that we can put all of our resources into caring for folks that are coming through our emergency departments with COVID and then being admitted to our floors. So it means more than just our units being overwhelmed or our ERs being overwhelmed. It means that a lot of people will also go without without the preventative healthcare that they need. It means that we will need to turn more clinic appointments to telehealth appointments and reduce in-person appointments. And we will need to very strongly consider our visitor restrictions and go back to early pandemic visitor restrictions, which essentially were nobody gets in here as a visitor with their loved one. And that's also terrifying, to have a loved one in the hospital and not be able to support your loved one when they're here receiving care. So it is important, I think, for folks to also keep those operational aspects in mind, that we will need to turn all of our resources to managing the COVID surge, which means that many other things will go unmanaged.
Like fixing our IT setup there, making it to where we can see people.
Where's Brett?
Okay, well, you shut it down, or I will fight forward.
Continue forward. If everybody can hear audio, then we'll just keep moving forward, and I'll.
Okay, well, let's move on to Dr. Scheit.
Dr. Pereira finished?
Are you done, Dr.
I am,
Pereira?
thank you.
Okay. I think
Yeah, thank you, Dr. Pereira.
Thank you.
I just have two physicians to present. They're just temporary orders because our credentials is meeting later this month. The first one is Dr. Justin Williams. He's an OB-GYN. He'll be joining us. And then the second one is Dr. Daniel Gladstone with Pediatric Associates. So we'd like to welcome them to our medical staff, and I'm applying for temporary orders until our credentials meets again.
Move to approve.
Second?
All in favor?
Aye.
Aye. Thank you.
And that is it for me.
Well, thank you for your comments earlier too, so we appreciate those.
Yes. Thank you.
Okay. So, we're moving into human resource. Debbie. Debbie there. Are we disconnected?
Am I reconnected?
Oh, yes.
Am I reconnected?
Yeah, we can hear you, Debbie.
We hear you.
Okay, great. Oh, it looks like you have the presentation up as well. Excellent. So first we'll go to marketing and community relations and talk about the campaigns coming to market, which includes the Whidbey Health Community Pharmacy. Now, this slide's a little out of date because we create the deck well in advance of this meeting. The speaking points around that were about the soft opening for the pharmacy, which we're excited to announce has had its soft opening for employees only at this time. And we're really excited in the coming weeks to be able to open community-wide, but that's been a terrific experience so far. The provider and employee recruitment is something that's getting a lot of Connor's attention right now. Recruiting is challenging in healthcare anyway, and in the current state with the COVID and everything else, we're even more concerned about what that looks like near term. And so hoping that the campaign will help support that. We're really excited to have a first appearance at a conference and have a recruiting booth, but that was canceled at the last minute because of the increase in COVID. So some of the efforts that were prepared for being backed off, being revisited. Maybe we'll be able to do some of it virtually. It's just not the same as having traffic come through your booth. And then there's been the Dnv Accreditation, which, excuse me, in terms of the marketing side of that, John will speak obviously to the accreditation, but from a marketing standpoint, Connor put a lot of effort and continues to move forward with that, but I don't want to steal John's update, so I'll just move past that, talk about some things that are coming up. And so hospice and palliative care, as well as cancer and Tour de Whidbey. Now, Tour de Whidbey, if you don't know, it's coming up on August 21st, and there are many volunteer opportunities, both for employees and community members, and you can reach out to either Heather in the foundation office or Annalise of rehab, and there are more people wanting to volunteer. So that would be terrific. And then we're happy to announce that the going to have a new feature for veteran resources starting in August. And so Connor has been working to not only come up with the information for the first section in August, but also going forward and having a whole marketing plan around that and providing information for our vets. As it has been pointed out in the past that that is a large section of our community and who we serve and how we may be able to provide a better patient experience and better service. And so that is also a focus. As far as employee health, there has been a lot of energy put into the COVID-19 plan and training. July 21st was when the COVID-19 temporary standard went into full effect. And part of that was we needed to review exposure control plan, and there was training that was assigned that I want to thank everybody who's been cruising through that. And emergency temporary standard exemption areas. So for people that are fully vaccinated, there are some exemption areas right now in the hospital. For people that are not fully vaccinated or uncomfortable, then you can wear your mask everywhere. But there are some areas like HR is one example. And if you go down to the department, you see a sign on the door that points out that that is an exemption area with those qualifications. That said, there may be masking updates in the future, depending how things are going with COVID and what some of the mandates are coming down from the state as well. And then our final look at the incident and injury statistics on the next slide. Happy that we only had one incident in July, so downward trend. So, oh, sorry. And then there were some late minute ads there. We also have been looking at where the injuries are. So not just the type of injuries, but ED has a share larger than all other areas of the organization. A lot of that has been due to some behavioral clients and behavior. And so that's unfortunate. That really equates workplace violence and something that we're working seriously to provide the best environment for all employees. And then when we go to education, patient safety companion training, we spoke a little bit about that before. It's being born of PrEP and then ultimately of the DNV audit. And Christy worked so quickly to put that together and get that into place, and train the trainer, and was amazing. Has almost 150 people already trained in the duties to be able to support that need, as mentioned in the injuries. Some patients need some one-on-one, and patient safety companion will provide a better service. De-escalation training was July 17th, and it included members of the community. What was really exciting was that it was conducted in person, and we are having a slow return to in-person meetings and training. But again, we'll see how long that lasts and what happens here in the near future. And the mandatory education statistics appear on the next slide, and this is an incredible kudos to the education team and all employees. 86.72% completion for all mandatory education across the entire organization. It is a higher compliance rate than ever before for Whidbey Island. The expectation is that we obtain near 100%, but I really want to celebrate this success. And the managers have been doing a great job in using the HealthStream dashboards and tools and helping employees be accountable and being able to complete the training. So I'm sure the board joins me in congratulating this huge effort, although we can't see them right now due to technical difficulties. Moving on to the HR, Dag. Oh. Okay, looks like we missed a slide. We're welcoming Army Lim and Anthony Mendel into the HR areas, and so feel free to pop by and meet them. Army Lim is an HR generalist, and Anthony has come on as a temporary assistant. The Patient Experience Project, the HR lens, has a focus from the employee side. We talked about performance management and how rolling out an improved tool set this year. And that project is doing very well. We're now at the 50% completion rate of that project in terms of being able to roll out this brand new performance management piece that in doing annual reviews, we'll be able to connect back to the values of the organization. And really the goal here is that for patients to have an incredible experience, they're having engaged employees, and fully engaged employees. They're shining areas in their professional accomplishment. We'll receive notation for that in the reviews. And so really proud of how that's coming along, and we'll continue to report on that. So that's one element of employee engagement. High engagement also leads to retention. And as I mentioned earlier, that is an issue of concern and something that we are looking at. What other things can we do to support retention? We've rolled out the new wellness incentive. If you walk by the HR department out in the hallway, you'll see a new display case that is filled with some of the incentives that can be earned, and we'll be talking more about that in the future and how people are earning those things. I will make a plug again for Tour de Whidbey. That is one opportunity for people to earn some wellness points. So, and then I want to talk about the recruiting challenges. So not only are we having the questions and concerns about masking and the mandated vaccine proclamation coming out from the state, we already knew that healthcare was challenged with staffing, and that is not just Whidbey Health. That is not even just healthcare, that's industry wide, right? Wherever you work, you probably have information going out for hiring. Wherever you drive, stores that you walk by, you see the for hiring signs. It's interesting. So many people are hiring, and yet we still have this unemployment rate that doesn't match up with the opportunities available. We're hoping that next month that we start to see that trend change. People hopefully feeling safer about returning to the work environment, combined with some of the federal monies falling off that helped people while there was a period of unemployment. And then our final look is at the exit data, the termination data that appears on the final slide. The largest sector of the pie chart are resignations, and we're continuing to break down the reasons. In the coming months, we'll be able to break down more specifically for departments, managers, et cetera, although we will be communicating that with those areas first. They're not hearing it here for the first time. Start to see some trends. So people resign, but why? You know, is it really just another job opportunity? What made them seek the other job opportunity? And that's some of the conversation that we get out of the exit interview, right? Okay, we get that you resigned, but what made you? Was it the leader? Is there something the organization can do better? And we're continuing to look at those things and excited to implement here in the coming weeks some of those, but I don't want to put more than that as a teaser out. So that concludes my part of the presentation. I'm open to questions.
Debbie, I just had a thought. That resignation piece of pie is pretty healthy. I'm wondering how many of those resignations might have been part of the RIF situation.
Oh, I actually, thank you. Excellent question. I'm sorry I didn't point that out. I actually have, this chart represents data without the RIF, because the RIF, of course, was largely involuntary, right? So I'm looking at voluntary resignations in this term data and breaking down the reasons for those. Although I do separately have the reduction in force data, and some people did volunteer, and some of that was motivated by the package. But even in those exit interviews, people provide data about what would even make them think about leaving their position. And so best case, you know, that you want more like 9 to 12 months of data, but we have a good solid 6 now. And it points to some things that we could do in terms of retention is fed by engagement, and things that we're working towards improving engagement, hopefully will show a reflection in this resignation sector in the coming months.
Thank you.
Debbie, I have another question about the dashboard. It looks like retirement appears twice, in the lower right and in the upper left.
I apologize, and we'll have, there was some that was.
Two different?
Yes, it is. It's, so it actually should be grouped together as different types of retirement. That's going to break out better in the why did you retire data. I apologize. It actually,
No problem.
does belong
And so
together and going forward when there's further breakout about the detail behind, but I'll make sure those pie pieces are next to one another. We'll just rearrange it differently so that the combined percentage shows as well. And if we expect retirements, right? We've been talking for over 5 years about the workforce retiring out and the need to bring in earlier in career talent to be mentored by the talent that is reaching retirement age. And that trend continues, and that is as important as ever. One of the things that we're looking at are more creative approaches to the resignations and exits. Maybe people are ready to end full-time work, but maybe they're open to per diem, a part-time opportunity, because we really do want that mentoring and that depth of knowledge that the body of people walking out at that point in their career take with them, right? So that will also be part of retention and engagement for employees because of being able to provide that kind of training and guidance, coaching, mentoring.
The other thing that I noticed, and maybe you can comment on this, maybe it's an aberration, is that the military transfers are a very low percentage. I thought, I always had the impression it was much higher than that.
It's shocking, isn't it? It's shocking data to me too. We'll just say that. We'll look at prior years and see that it was a little higher in prior years. Right now we have more people also moving in than moving out is part of it, as we know that the housing crisis in part is due to all the military that we know is still coming in. So there's mixed reasoning behind it. That's a very interesting data point. You would have thought that it would be as big as the resignation chunk, right?
Or at least higher than 5% or 3%.
Yeah. Or they're not telling us that they're military connected, right? There's always room for skewed data that way.
Thank you.
Anything else, Debbie?
Thanks, everybody.
Thank you. Now for some happy news. We've got Jennifer coming on to tell us all the great things that are happening financially.
Such pressure. Let's hope so. Good afternoon. Can you hear me okay? Sometimes my microphone doesn't work very well, so. Okay, well, we have July volumes. We're gonna have June financials, but we're far enough in the month where we do have the volumes for you. So overall, you can see that inpatient volumes are projected to end about 2% over our budget. But I predict that's going to go up a little bit more as we go along if we keep seeing the volumes we're seeing now. As you can see, in July, we had 142 admissions. Our average length of stay was 4.3 days, which means they're staying a little longer. In our case, it means we had a few patients that stayed with us for quite some time. So you'll see the patient days are also up, way up over July of 2020, and projected to end about 9% over our budget. That's mostly due to a lot of ICU patients and again, those patients that are staying with us a little longer, I guess because we're so nice. Or Aaron would have a different story about why they're here anyway. So our average daily census is up and projected to be up over our budget. And if you can see July here, we were averaging almost 20 patients a day. So that's huge. Any questions about that inpatient volumes?
Any questions? Nope.
Nope.
Moving on.
Okay, moving on. You can see your emergency room visits are still low for a projected total for the end of the year, but I again predict if our volumes continue the way they're going right now, we'll be at least matching our target. You can see in July, we had 1,948 visits to the ER, and our walk-in clinics were also very busy. Just put them there, hoping that's what you were talking about, Greta, wanting to see. So, so you can see that I have not adjusted this target for providers. And so we're a little bit skewed there on the target. I think we're closer to target once I flex to how many providers are actually there. And I'll do that for you next month. You can see here, inpatient surgeries are going really well, 10% over budget, and that's due to the total joint program. Outpatient surgeries are a little down, and I'm sure that that's due to not having our Navy performing surgeries here right at the moment. And let's see, ambulance was really, really busy in July. I've never seen it that busy. So overall, everybody was busy in July. Any questions about that? No questions. So here's the good part.
Yeah, I just want to say thank you for adding.
Oh, sure.
Yeah.
Happy to do it. You'll see our net patient revenue is right on target, right on budget, a little bit over for the year to date. One caveat there is I probably, you'll see our patient accounts receivable is quite high, and we may take a little bit of a hit on writing some of that down at some point, but we're still holding out hope to collect that. So then you can see our total operating cash. We spent 6% less than our budget, and that ended up the month at a profit of 363, almost 64,000 after depreciation, Nancy. So that was a good month in June, bringing us well over our budget in year to date. Again, I have some concerns regarding accounts receivable and some other things we'll talk about at the end, but for now, it's looking really good. Any questions about that? Nope. And then here's your balance sheet, and that 16 days cash is the thing that's worrisome to me. And you'll see the almost $20 million in accounts receivable. That's quite worrisome. And we're working on it by outsourcing to HRG and really doing a lot of work in denials, trying to get the money in. But at some point, we may see a little bit of a write down on there because the cash just isn't coming in. So there might be questions about that.
Jennifer, is most of that insurance money or patient money or?
Oh, I don't have the exact percentage, but a good portion of the older accounts, of course, are patient related, which HRG will be collecting on. I can't really answer that completely. I mean, our self-pay is probably about 4% of the total. So mostly insurance, and it's just all the excuses for not paying the claims, and then making us do the rework and the rework and the rework to finally get paid. So it's just getting older and older, but the AR team keeps hounding after them until they finally pay. Hopefully. So I think the over 180 days is getting up around 5 million, which is the really worrisome piece right there, is how much of that we really will collect. So more to come on that. We're, as I said, watching. Ron, you unmuted. Do you have something to say?
Oh, did I? Wait a minute. I don't know what I'm doing. Yes, HRG will be coming to the Finance Committee to express what they're doing.
HRG is over 90 days. So we will see.
Yeah. So some other interesting pieces of the balance sheet are these third-party receivables and the tax levy receivables. That's money coming in. We don't have to take a discount on that. So that's good. And then our liabilities are relatively low right at the moment in our current liabilities. So financially standing, I think we're in an okay position right at the moment. Any questions about that? Nope.
Oh.
So I wanted to bring
We're
up.
making it too easy on you.
Sorry, what?
We're making it too easy on you.
Oh, well, I'm sure you'll pay me back at some point. So I wanted to bring out just a few sort of identified key risks that are on my mind, and I'm sure on Ron's mind, keeping us up at night. That could be risks for our budget coming up next year. And just the really scary fact that so many hospitals, rural hospitals in particular, are closing, although we don't feel like we're on that list of imminent failure in any way, but the capacity issues with the I-5 corridor, any rural hospitals closing is going to have a real impact on our citizens. So that worries me. Our insurance companies continue to make things difficult for us. As you can tell by our AR aging, just my talk about our AR aging, they just make it difficult for us. And one sort of good piece of information was when we met with WISHA and I asked them, why can't we address this issue? And they expressed how difficult it was because of the lobbyists, but they are doing a report, at least a report on this and the difficulties that insurance companies are making for us. And the American Hospital Association, I did send that out to Finance Committee, and I'd be happy to share it with the rest of the board, did a study last year on just this, and I think WISHA is just taking up the case for that. So that's always worrisome. And of course, as Debbie talked about, our employee and workforce shortages continue. What are we going to be able to do? What are we going to have to do around that is worrisome for me. And then our age of our building, and we all know about our infrastructure needs, and that all comes around the USDA loan. Part of the USDA loan is getting the interim financing, which I think it's coming closer. So long story short, those are my key areas that keep me up at night. Does anybody have a question about any of those? Otherwise, that's all I have today.
I think all of us have the same question, is how did the insurance companies take over medical care and take it out of the doctor's hands? They get addicted.
That's the question, isn't it?
Yes.
Yeah.
Every time they do healthcare reform, they forget to take on the insurance companies.
And along that same line, the government likes to control all of us and set parameters for all of us. But for some reason, the insurance companies have avoided that. They have no parameters set for them on paying the bills to hospitals, to doctors, to whomever.
They have deep pockets. Yep.
Yeah.
Better lobbyists.
Okay, any other questions for Jennifer? If not, we'll move on to our nursing report. Erin, you're going to tell us how happy everybody is and eager to work.
Well, the folks that are here working come in every day with smiles on their faces, and we all I think I can speak for all of the nursing team that we love what we do, and we're here to provide care to our community. I think Dr. Pereira and Dr. Scheidt are very correct, though, that across our nation, healthcare workers are tired, healthcare workers are feeling burned out, and healthcare workers are making decisions about whether they want to remain in the profession. And that is the same here. But we have a great group of people here ready to take care of our patients and continue to do so every day. I'm proud of the work that this hospital does. We've seen some very positive commentary in Facebook, and I'm pleased to see that folks are recognizing the great work that we do, and they're calling it out when they see it. And if we have any of those folks that have been posting on Facebook about their positive experiences, please know that those words are incredibly meaningful and very touching to all of our healthcare workers. They get shared more than you know, even through the Facebook sharing. It gets shared all over our organization. So it means a lot to us to see those comments. So please keep them coming. We'll keep doing a great job, and please keep commenting on it. We appreciate it. We've had some luck with recruitment. I think maybe there are some slides for you guys, but we've talked, my first slide is all about COVID-19 and the pandemic and the rising case rates. And we've talked about that at length. So I'll just skip over that entirely. That data now is about 2 weeks old anyway. But some good news is that we have filled a couple of positions. So I'm very pleased to congratulate Tabitha, who is joining our Whidbey Family Birthplace team as the manager of that team, and excited to have her in that role. And we have a trauma coordinator identified as well to fill that role. As many of you know, Bert moved from his position over to Brett's team and is working now in clinical informatics and just doing an incredible job there. We have some applicants coming for the ICU manager position and the hospice manager position. We've had some hospice medical director interviews too, and we have a candidate that we've made an offer to as well for the utilization management and social services manager position. So that was Tabitha's former position. So now that she's moving into a different area, we'll refill her position in utilization management and social services. So some good work there. We are getting some positions filled. It's slow, it's arduous, it is an uphill battle, but I am excited for the folks that are being promoted from within and finding the areas of work that they are the most passionate about. So happy that we've been able to move some folks internally into positions that they're very excited about. Our ancillary needs and our nursing needs are great. We have a lot of positions open, and we need people. We need to get more people here, and I'm so thankful for the help of Debbie DeCordy and the HR team and all of the just really creative recruiting strategies that we are working on and working through, and the continuing dialogue that we all have as an executive team about how we can get more people here to Whidbey Health, being creative with regard to housing options for folks and what Whidbey Health can do. I think we're talking about all sorts of promising ideas that will help us recruit and retain staff. So happy that that is work that we're doing. But we are challenged with staffing, and I think it is important for the board to know that we will be using the help of some travel staff resources, particularly in respiratory therapy and in some of our nursing departments, to augment the staffing that we do have. And also to give our teams that haven't had a chance to take a break or take PTO or get vacations to allow for that, but also to continue the great care that we are providing and to just help bolster the reserves of the folks that we do have. So we are getting some fantastic travelers here and on site, and have already started to work in many of our departments, and the reports that I get are glowing. So with any luck, we can turn this into a recruitment opportunity as well. But we're happy to have that support. It is important to know that we are we're competing with other organizations across the state and across the nation for these travelers. So the rates that are paid are not low rates. We're paying expensive rates to keep up with the competition for these finite resources. And I think it is just a good opportunity. I said it before, and I'll say it again, but healthcare in this country is a finite resource. It is not unlimited. and our island is no exception. So I think we all get into the mindset that healthcare is unlimited and available all the time and for everyone. And I certainly wish that that were the case, but it is a finite resource, and it takes a lot of people to provide the care that we provide. And so we've got to get some more people here. So if you know people, refer them to us. We are actively seeking these folks and want to grow in our teams. But some other things that we're doing besides talking about recruitment and retention, we did welcome Dr. Williams and his lovely family. We had a breakfast so that he could meet many of our women's clinic and labor and delivery staff. So that was fantastic to have him out and to be able to welcome him. And he starts next week. So excited to bring him into the team. And I'm also really pleased to announce that we are moving forward, and this week we started our all MAC model of endoscopy. So this is monitored anesthesia care. So it's anesthesia care provided by our anesthesia nurses, and is, I think, going to be just a really incredible opportunity for our patients and for our providers. So this type of anesthesia, you recover from it quite a bit more quickly. It's being provided by one of our CRNAs, and it keeps the provider that is performing your procedure from having to monitor both the anesthesia and the procedure. So your provider is focused on your procedure, your CRNA is focused on your anesthesia, and you have fewer side effects, you recover more quickly. So this is a great step in the right direction here. I'm excited that we are offering this to our community. So a lot of work, a lot of people have worked on this project, and finally to have it come to fruition is pretty exciting. And along the birthplace, so we've been in the women's clinic, we've been doing a series of rapid cycle improvements. We've contracted with a couple of clinical analysts and informaticists who've been able to really help us look at some opportunities to optimize the workflows in our EMRs, because that is an area where 2 EMRs are used simultaneously. And so to make that a better experience for our staff, our providers, and our patients, is exciting to see that work coming together. And then I'm very pleased to announce that we started really honing in on and structuring a debrief process after every C-section, every labor, and that has been such a wonderful opportunity for our providers and our staff to get real feedback and think about what we can do to enhance the care that we're providing. So some great work coming out of that team. A lot of great advanced education coming out of the women's clinic and labor and delivery, and our teams are working on all kinds of simulation drills and trainings, and our providers, Dr. Geem, Dr. McSorley, and our certified nurse midwives, Hallie Granville and Alicia Dar, have been doing a great job at providing education and in lecture format and didactic format, as well as hands-on skills training. So that work is ongoing and is being very well received. And then a lot of work still happening around our Dnv action plans. So we're thrilled to be working in these areas and honing in on the care that we provide and the documentation that we complete to make sure that we are in compliance and working through those action plans. So in fact, just prior to the board meeting, was in a meeting to talk about chart audits and how we can fine tune the documentation within our EMRs so that we're capturing all of the necessary components. So lots more work happening there as well. So a quick and brief report from me.
Well, we appreciate that. Is there any other questions for Erin? We're letting these people off too easy. Thank you, Erin. Keep up the good work.
Yeah, I think we're seeing a lot more action in the positive direction, and so our questions aren't as numerous as they were.
No, I think so. I think you're right. I mean, there's a lot of positive things happening. Very impressed with the staff here, all the way through, from the top to the bottom. And we'll move on to quality report. John.
All right, thank you, Commissioner Wallen. So I do want to start off just by talking a little bit about our Dmv survey. We did have a condition level finding that required a return visit by the Dnv surveyors. So we actually had that on-site visit on August 3rd. Aaron and I corralled this person and walked her around and showed her what we wanted her to focus on. She came ready to fire with a lot of great questions for us, but the bottom line was that our condition level finding was closed out successfully, and we received quite a few compliments on that. And I definitely think we have to call out the great work done by our ED. Our ED staff were on point. They were really the focus area of that, of most of that review. And every staff member was doing their due diligence. We actually had a patient in-house at that time for the surveyor to review and see us in action. So our staff did a fantastic job. Can't call out enough our fantastic education staff as well that really helped Aaron and I get this information out, get this disseminated to all of our pertinent staff, so that not only could we be ready for this return survey, but honestly, the bottom line is providing the safest care that we possibly can. And this is just validation of the fact that our staff have that dedication. So very happy to report that that has been dropped down to an NC1, which is a nonconformity one, which is what half of our survey findings were. And when we submit our corrective action plan evidence, probably in the next 45 days or so, we would expect that's going to prompt us getting our official certificate, which we want to take around, we want to show off, get a lot of pictures of, and really be proud of the evidence of the hard work that we've all collectively done. The other thing that I'd like to point out around our quality management system is that it's going extremely well. Our key performance indicators are all stable or improving actually across most measures. And even when they're not, we're not seeing precipitous drops, and we're not seeing drops that are due to lack of attention or lack of dedication to a process. We're seeing these as direct results of the issues that have already been brought up, i.e. our shortages of staff. So let me pick on the ED because I just complimented them, right? ED medication reconciliation, for example, fell by 5.55% from the last month and is 11.47% off of their peak, which happened in the month of March. Now, that's not due to anyone doing anything wrong. What that's due to is the fact that they have sustained incredibly high volumes, and they have had a bit of a staffing crunch. The great example of that is the ED manager herself has staffed in. I don't know, Aaron, how many times would you say that she's actually suited up and done bedside care as a nurse, not a manager?
Oh, so our manager has been staffing in full-time routinely for the last month and a half.
Yeah, so it's a great testament to her dedication and to her staffs, but ultimately not a sustainable situation. So I'd say under the circumstances, I look at that drop in that compliance really as an aberration and very due to the circumstances that we're under. With all of that being said, looking across each of our measures, we really don't see any significant barrier for us to be able to establish our targets by the last quarter of 2021. For each and every one of these measures, we will have at least 12 months of data to support creating realistic thresholds for performance moving forward. And I think we are, in my opinion, starting off by setting the bar pretty high because our staff have already been doing that. We are optimizing still all of our data sets. We will be done by August with all of our KPIs that we currently collect on. As a reminder, that is going to be included in the packet, the board packet from pages 36 through 84. The measures that are indicative hospital measures are what I'm pertaining to. But we are looking to conclude that optimization, have those data sets finalized. We're about 97% there anyhow, and then we'll be turning our attention to our outpatient data. This is the data that we pull out of our Athena Health record. We do not foresee that that will take as long as it's taken for the Meditech side of things, because on the Meditech side of things, we actually started almost from scratch. We were building this curated data set from the ground up, whereas there's already been quite a lot of work that's been done by the company that we've contracted with, True North, historically, and Andrea Heggenes, who's also been the POC out there in the clinics for quality and quality initiatives. And finally, on this piece, IT is working to establish user accounts in order to provide access to the dashboards. So we're diligently trying to move that forward. We foresee that happening hopefully here pretty soon. And I have a feeling that when you see that, it's going to open up a whole new world of understanding and questions, good questions that we definitely want to start throwing around regarding our data set and our trended performances. Moving on to patient experience. At the time of submitting this report, our composite mean was 4.61 out of 5, which is very, very good. National benchmark, as a reminder, is 4.77. We continue to see that improvement with slight up and down deviations. So an example is we received a whole bunch of survey returns recently where we had as a consistent statement, or I should say a consistent low score on a statement, being kept informed of unexpected delays. So the complaint was, I'm coming in for my appointment, I'm coming in for into our lobby, and I'm sitting for a while, or no one's really coming back to me and telling me, hey, we're going to be with you shortly, or hey, here's what's going on. So basically sitting and waiting without communication. We have started to address that already with the rollout of our customer service always behaviors. So that's on page 80 of the packet. It looks, this is too small to see, but it looks a lot like that. We've got 10 items on this packet with contact information at the bottom. Again, page 80 of the board packet. Number 5, if a patient is sitting in a waiting room or exam room, do not let them sit for more than 15 minutes without checking up on them. Apologize for the wait if things are taking too long. So we are definitely making that a high focus, basic customer service approach in all of our forward-facing areas in the organization. In addition to rolling this out to the staff and rolling signage out that we can post in various spots, we've also rolled that out in tandem with these. These are mirrors that we've asked, as people are speaking to customers, patients, have these mirrors posted up. Look at your face while you're talking, even if you're wearing a mask, even if you're on the phone. I, for instance, I'm not great at this, so I have to definitely rely on the mirror quite a bit. Sometimes when I'm on the phone, I've definitely used our tool myself. It's, again, creating that awareness of how we are presenting to our community as they're coming in seeking care. We're starting to see the fruits of this labor across the board. We are starting to see reflected in our scores comments that I was treated so well, so thoroughly. We had some glowing comments come through regarding our ED and our EMS teams, who have done a phenomenal job of not just providing exceptional care, but providing that impression of exceptional care. Perception is 3/4 of the equation, and these patients are sharing their perception that they received collaborative, caring service from both of these departments. So again, can't speak more highly about our ED and EMS in that regard. With the Patient Experience Initiative, we've also had sub-teams dedicated to certain aspects of our project that have been meeting. We have been getting these items completed. We had our first set of due dates by end of July, with predominantly every one of these getting done in time. So the work is definitely assertively continuing. All right, if we could go to the next slide, please. For patient safety and risk, we had our new event reporting system go live the week of the 19th. Very proud to report that it has been a success on every single front. To date, since the 19th of July, we have 133 events that have been entered into the system as of this morning. That is huge. That's a huge testament to how much trust our employees have given to the process of just culture, see something, say something, and preoccupation with safety. The quality of these events has been astounding. I've worked in the event reporting system business for a number of years. The quality of the event types, the reports, the kinds of instances that people are putting into the system, I honestly could not ask for more from our teams. So with that, I hope that's taken as a lot of good news. I do share the challenges that have been expressed already regarding staffing, regarding resources. Right now, if I was pinned down and you asked me what is our top vulnerability, what's our top risk as an organization, it would be that very thing, making sure that we have the right and qualified people in the appropriate places, doing the appropriate work. And with that, I'll take any questions if anyone.
Any questions?
Thank you for your good work, John.
Yeah, thank you, John.
Thank you.
A lot of good news. Moving on to our IT report, Brett. Is Brett there?
He's having IT problems.
He's having IT problems.
Oh, Brett.
Sorry, I brought up my presentation and then I lost my mute button. When my mute button went, it went to the top of the screen. My apologies. Everybody can see the information technology update on the screen?
Yes.
All right. So I just wanted to give you a brief update. I've been doing this quarterly on the sort of ongoing narrative of the IT transformation that we're going through right now. So I have 6 key things that I've been reporting on. I just wanted to briefly give you an update on those. So first and foremost, as we look at our insourcing of our IT department, we are about 65% complete, and my hat's off and thanks to HR for all the work that they've been doing to help us do this transition of going from an outsourced department to insource. We still have some big hurdles to go through yet, some harder positions to recruit for, I've noted on the screen there. So we might be partnering with some folks outside the organization to try to secure those kind of folks, but so far things are definitely headed in the right direction for us to have a smooth transition come March of next year when the contract ends with Allscripts. We talked about security last month, so I won't spend a whole lot of time here other than saying that we've got things well underway with our security and compliance related efforts. We just went live with 2-factor authentication for VPN here recently, and that's gone well. So people who are remotely accessing our systems will now have to provide something beyond just their password. They'll also have a notification on their cell phone for most folks that they'll have to acknowledge that they're actually trying to access the organization. So that's why they call it 2-factor authentication. We've also, based on our state auditor feedback and based on best practices, we've recently changed our password format to 11 characters and some other elements there to make our passwords a little bit more difficult to crack. At 11 characters, with the formatting that we're doing now, it's approximately 4,000 years for somebody to crack those passwords. So we should be good to go on that. We're also regularly doing patches of all of our systems, which we weren't doing before. And So all of our systems are basically all caught up and current, and we're on a regular schedule every month to make sure that any patch comes up for an operating system or an application, that we're getting those security patches done. We're also continuing on with our Office 365 deployment. And again, the reason this is important is because of the email auto encryption. We're looking at some other solutions like secure text messaging, and so a whole variety of things that are really well underway. So I'm very pleased with how those are moving forward right now. As far as process improvement goes, there's a whole number of different initiatives here, from project management and using a formalized process and a new tool. We're using Monday.com to manage all of our projects, which is a web-based project management platform. We've got a formal change management process in place, developing our service management and the standards for how do we care for our users in the organization and so on, as well as continuing to develop our governance model. So we've got the 2 other committees that I'm looking to get formed here very shortly. One with our physicians within the hospital and partnering with them on a monthly basis to continue our Meditech development and other related application development, and then also one for the practices with the providers and the practice managers there, meeting with them on a regular basis so that they have a chance to weigh in and have a voice in how IT resources are being applied to support them. So we're continuing to develop that smaller diagram down below in supporting the organization with IT services. As far as kind of keeping the wheels on the wagon, we've got to do upgrades and updates and take advantage of all the functionality that we've invested in with our applications. And so we've recently done a fairly meaningful patch with Meditech here, and we did a pretty big upgrade with Athena Practice for our clinics, implementing an upgrade for Redoc, and a variety of these things that were in process of either upgrading and they've either been done or we're in the process of tuning them to work even better than they had before, kind of taking advantage of some of their other functionality that we might not have been using before. Faxing and fax management is one of those. We did an upgrade, and now we're going to start to utilize that, some more of the virtualized management for faxes going forward. So lots of good stuff coming and getting our applications current and taking advantage of them better than we have in the past. We've also got a lot of new applications coming into the organization. So John referred to RLDatix, which is our incident reporting platform. So that's live, and his Power BI, his quality reporting tool that they've been working on, and we're continuing to develop that in partnership with his team. We've also got a now house-wide notification tool where we can send messages like a ticker tape message across the top of computers, as well as broad screen messages where if we have a code and this is coming, we have the whole screen pop up as a code yellow or code pink or whatever, and give critical information to our staff if something's going on. And we've also implemented a password self-service reset portal so that if somebody forgets their password or for some reason gets locked out, they don't even have to bother calling IT anymore. They can if they want to, but they could also go out to a URL, go out to a browser, wherever they're at, anytime, day or night, and reset the password themselves. Probably like you've done many times with other services that you've had on the internet. And then a whole lot of other projects that are in process that are coming. And I wanted to talk about the Parlance interactive voice response and kind of highlight that, but I'm going to talk about that in just a moment. And the last item here that I want to present is just talking about how we're working to make sure that our systems work well. So how we stabilizing things. We're still working on the phone system and getting that to be working well, but we've got it boiled down to 4 key areas where there's been some chronic issues that we're addressing, and we've definitely partnering very closely with our telecom company that we purchased and getting those resolved in short order. We're also doing the planning of our life cycle and the aging equipment that we may have here and there and getting that replaced in a timely manner and so on. So all of those things are going well, but I kind of wanted to fall back to the phone system a little bit and talk about that Parlance product I talked about here in the new applications. So one of the things when we went live with our new phone system back in December is that we went to a phone tree, kind of a classic model for a lot of organizations where press 1 for this, press 2 for that, and then you press the number and it probably takes you through the phone tree again. Press 1 for this, press 2 for that, press 3 for this. That has been highly frustrating to not only our own employees that are calling across organizations, but to more importantly to all of our patients and our customers here. And so you can also look at this as an element of that patient experience effort. And I wanted to give you an idea. I'm not sure, since I don't know how much we've done this in the past, if you're going to be able to hear this. So I'm going to press some audio what the new interaction is going to sound like probably in the next 2 months when you call into any of our main numbers at any of our sites. We'll see how this goes.
Thank you for calling General Hospital. Who would you like to reach?
Yeah, hi. Medical records, please.
Okay. Are you a patient or a provider?
I'm a patient.
Thank you. Please hold.
Did everybody hear that okay?
Yeah.
Okay. So it's more of a regular, like you're talking to a human. And I'm sure, again, you've had experiences with other organizations, other corporations that have something similar. I'm going to give you another example here.
Thank you for calling General Hospital. How can I direct your call?
I'd like to make an appointment.
Okay. With which provider or specialty?
Radiology.
Would you like appointment scheduling with East Peak Radiology or South End Radiology?
East Peak.
Thank you. Connecting you to East Peak Radiology scheduling.
So that'll be a much faster way to access as somebody calling into our organization to access what they want to access to. And there's a fallout to this in a good way, meaning if the person's language is hard to detect, or if what they're asking for is we didn't set it up to be an obvious pathway into the system, and it's just that we can't figure it out, they're not going to have to go through this long talking to the computer thing. You know, after a couple tries, it'll then fall out to an operator who will take the call and try to work with the individual. But 90+% of the time, it'll be able to route them directly to whoever they're asking for, which will be a much more satisfactory experience, and again, a much more human experience for folks calling in. We think our patients and our visitors will enjoy that much more. And the side benefit of this, we can also use this tool internally. If you need to call somebody else in the organization, but you don't know their extension, you don't remember what department they work in exactly or whatever, you can dial one of our extensions that will reserve for this and just say, I'd like to speak to Ron Tellis, and it will then forward you to that person, whoever it is that you're trying to call. You just speak their name and they'll forward you to that extension. So it'll be very convenient for our staff in trying to make calls internally back and forth as we've, we're a big distributed organization, and that'll make life a little bit easier. So I just wanted to share one of those changes as well. That's everything that I had to talk about. Whoops, sorry.
Who would you like to reach?
Oh, I'm doing both of them now. Anyway, that's everything that I had. Any questions for me?
No question here, Brett, but that phone setup sounds fabulous. I have spent many hours on the phone waiting to get through to who I needed to get through to. And the concept that you just shared with us sounds like world of difference.
And it'll also be a world of difference for our own employees. So Maria Reyes's group, kind of gets inundated with so many calls and trying to manage all different kinds of traffic. And so if we can kind of minimize the number of times that they actually have to play phone operator, that'll be really, really great for them. And then they can focus their attention on other equally as important things that they're working on. So it'll also be very efficient for internal processes as well.
Thank you, Brett.
Thank you.
Brett, I have one topic I'd like to ask you to address in a little bit more detail, and that is the Cabot Clinic phones. Are we still having problems with those, and can you bring us up to date?
So this is what I mentioned previously, we've got 4 kind of key areas that we've been working with Mitel, that's our phone system, the company that we purchased for our phone system, that we're trying to resolve. We're in High Point was the company that we partnered with to actually get this implemented. So we're actually working with both of those organizations. So we are making progress. This has now been escalated to the engineering level at Mitel to help us resolve them. So we've got the attention actually, I've worked my way up to the executive level at Mitel to get assistance with this. Some things I think we're discovering, and we're kind of waiting to see if this is really the case or not. There are some things that were probably just needed to be retrained on, and we did some of that with call transfers that may have addressed some of the issues. One of the issues has been fully identified as a bug, and that's in with their engineering team to develop a patch, so we're waiting for that. And then we're also collecting some additional data to give them on our systems so that they can help do some further troubleshooting and get these things resolved. The issues are beyond Cabot, but Cabot has a very large phone volume. And so it kind of is the higher visibility area for phone issues because of that. And so, but these problems are replicated randomly throughout the organization. But that's kind of where we're at today. And I've been providing regular updates to the executive team and to key leadership, especially at Cabot, to let them know kind of where things are at. So the last element that I'm working on, trying to turn over every stone possible to try to get the phone system issues resolved, is I'm also going to be trying to schedule a network review. Now, we've replaced all the cabling in Cabot altogether. It's got brand new networking equipment, brand new Wi-Fi equipment. That Wi-Fi equipment's been optimized, but we haven't looked at the configuration of all of our networking equipment. So I had that idea the other day that, you know, maybe it would be worthwhile to have an outside expert, a consultant, come in and just like, do we have everything accounted for in our network? And just to make sure that we haven't missed something that could be a fly in the ointment and we're just not seeing it. So so between working directly with the phone vendor themselves, working with our telecom partners, and working with looking at the other different infrastructure elements, I'm hoping we'll be able to put this to bed soon. It's been a long, hard road to get to this upgrade to a workable state.
And are these issues that we've been running into, are they problems with the Mitel system itself, or our system, or they don't talk to each other well, or?
So everything is really centralized to the Mitel system, but the Mitel system, like any kind of digital phone system, runs over our network. And so that's why I'm like, well, it's another thing that we haven't dug deeply into, so let's take a look and make sure that we don't have some other hidden thing in our network itself. But the Mitel organization, the Mitel company, is actually looking at their programming, looking at their design, looking at our patch levels, because it's really an application. And so they're looking at all of that to try to figure out why we might be having some of these issues.
Okay, thank you.
Thank you. Anything else for Brett? No. Moving on. Going to facilities update. Tim.
Yes, thank you, Commissioner Wallen. So there is a lot going on, a lot of waiting, but we're working very closely with a lot of engineers in the town of Coopville and Department of Health. The occlusion room and the floral room, they have, the town of Coopville has completed their reviews and given us some comments back that we're working on so that we can get those comments and changes to the Department of Health so that hopefully in the near future we get approval. We do have about 4 contractors that have bid on these projects that are patiently waiting so that we can award those bids. For the MRI pad, we are still waiting for Siemens. They have submitted plans to the Department of Health so that we can get a new MRI placed outside while we are working on trying to get the MRI and CT updated in the near future. We have, I think we're expecting our new air handlers for the lobby and Clinton around mid-September. So hopefully, everything is on back order, and there's a lot of delays on supplies, equipment, and everything else. So we're expecting those around mid-September so that we can get those units installed and up and running. We are going through the process of picking out equipment on the chiller and boiler projects. We've been having a lot of design meetings and going over the structure and supports for the new chiller. Reviewed the spaces for the new boilers in the basement of this existing building here in the admin wing. So a lot of work being done to get these systems upgraded. You know, we do, as Jennifer mentioned, there's concerns with our infrastructure. We're doing everything we can to address these things as we can and as soon as we can. We're also busy in facilities preparing all of our clinics for rural healthcare review and relicensing. So we're spending a lot of time doing some updates, painting, flooring replacement. At Gold, we'll be fixing the roof up there in the next month or so and having that sealed up and replaced. As far as Dnv, we have pretty much completed everything that was on our list. On August 24th and 25th, we will be replacing the hood suppression system and getting off the water heads that are currently in there and adding a manual release also that is part of the code. So that'll be the big things that will be getting completed here in the near future. Our USDA loan, we're still working through getting the contract signed for Aldridge. That changes there and getting that completion so that we can hopefully move forward and get pricing on that project. In the near future, we'll have our signage is going to be redone kind of from the main entrance, get people through to the elevator, to PACU, down to medical records, and hopefully assist with some of the complaints that we've had with our signage without having to redo it all, but try to just correct some of the issues that are there currently. WSHA has will be receiving a safety award for the facility. They did a review about 30 days ago, found a few things we needed to address. We have completed those things and they'll be coming back and we will be receiving a safety award as one of the top safety hospitals in WSHA. So that's a very positive thing that's coming. Those are the main things right now. If there's any questions, be glad to answer them.
I'm glad to hear that we're getting an award for being safe. That's great.
Yeah.
It's always good.
What?
Good.
Excuse me. What is the status of converting the rooms in the new wing to have an operating room for C-sections?
C-section. Well, that's part of the USDA loan. So once we get that, the contract approved by USDA to get Aldridge on board, then they will finish doing final pricing. And the final pricing will be presented to the board. If that is approved and Jennifer approves moving forward, then we will, that'll go out to bid for subcontractors. And so we're thinking, conversations I've been having with Jennifer, and Ron, this could be something that could be as early as next spring or next fall that we actually start that project, which is oncology build out, the lab model, the C-section portion, some infrastructure within the building, moving sleep down to where oncology is, and moving wound care over to where oncology is at this time also. So lots of little different moves and things, but hopefully in the near future, we're doing everything we can to keep this moving, but our agencies that we work with are, a little slow and probably have a lot of things that they're doing besides just our projects. So we're just being patient.
Thank you.
Thank you. Thank you. Any other questions for Tim? Well, thank you, Tim. Moving on to strategic initiative update, Kevin.
All right. Thank you, Commissioner Wallen. Appreciate it. Let's see, my slide deck. Do you have the slide deck by chance, Melanie?
I do. I'm just getting it up now.
Awesome. The first thing we'll be talking about, that first slide, is going to be about employee engagement. We originally intended to launch our next Gallup survey on employee engagement in August, and that was the date we were talking about. And we decided that it would be very helpful to get input from frontline employees around the organization who would help us to make better decisions around that survey. And so we sent out an an email asking for volunteers, and had about a dozen individuals in the organization that raised their hands, said yes, they'd like to be part of it. And one of the first things we discussed with them was our start date. And the feedback overwhelmingly from them is that August is a terrible time to try and implement a survey. They said that everybody was away on vacations, children and kids were still not in school, and that if we wanted to improve our participation, we needed to push that back until their recommendation was late September. And so we discussed it with the executive leadership team. They agreed that their reasoning was sound. And so we have rescheduled our employee engagement survey to the end of September. The next thing that we've looked at with the Employee Engagement Advisory Council is the naming protocols. One of the challenges we have had in the past is that some individuals had a hard time figuring out what department they would belong to. So at the beginning of the survey, each employee is asked to identify which department they belong to, and we want to make sure that the naming protocols that we put out on the survey, that it makes it easy for them and that they're familiar with everything in there. So we've been working our way through that list, cleaning them up. We found lots and lots of changes that they wanted to recommend, and we still have about 9 items that have yet to be resolved before we're ready to put that entire list in front of the executive leadership team with the new naming protocols. So more to come on that. Next slide. So one of the other key things we've been working on is our denials management. And at the beginning of the year, we focused on putting together our own internal denials log so that we would be able to focus on preventable denials, things that where we inflicted our own injury to ourselves by our own practice internally. And so early in that effort, a lot of the focus was on making sure that we actually had good data, that we were putting the right information into the spreadsheet. Once we had reached a high level of confidence there, then it was focused on making sure that everyone in the organization who would be addressing these denials, that they had the tools and an understanding of the process. And we've been able to accomplish that. And now the focus has shifted to working down the backlog, making sure that, that we are in a habit of staying on top of it. And we've been really excited to see that, that a few things are happening. So if you look at the first chart there is, go back, thanks, there we go. It's a dispersion of all denials, both open and closed, that are on the denials log. So this shows you the number of denials that exist and the month of discharge. And so you can see that, that we had a lot of older denials in the backlog that, that were entered in, some of them dating all the way back to 2019. And then a lot of them from March. But since March, that number has been coming down. And that is predominantly due to 2 things. One is that, that the frontline leaders who are responsible are now getting really good information about preventable denials and are working to prevent them from happening in the first place. And this increased awareness on those denials is helping us to work them down more quickly also. And if you look at the second chart, that is open denials that are currently in work, and it is by month that they were discharged. And so you're looking to have a curve where most of those would be current. And you can see that that is in fact the case. The key thing that we're working on is that past months of things like April, May, and June, we want those numbers to be really, really low. We want to have already resolved them quickly and in a timely manner. So that's where we are in the project currently. We're trying to get into that habit of addressing things quickly and early. And as we get a little bit further into this, the emphasis will shift from reacting to these to a more proactive stance, where we start focusing more and more of our efforts, not on addressing them quickly, but rather on preventing them from happening in the first place. All right, next slide. These are just an example of how we're parsing the data so that you're able to see some of the things we're looking at. So we're able to get in and see what kind of patient type are the open denials that are out there, and which departments do we need to focus most of our attention on. Also, what are the denial types that are showing up? And so not only the departments where those denials are coming from, but what kind of denials are they? And we also get into a lot of other aspects, like who are the payers, the insurance companies that are giving us the most denials and why. All right, next chart. And I needed to put this one in there for Nancy's benefit. I needed something that would not be legible, like you would not be able to read it. This is a representation of some work that we have done on patient experience. This is a workflow, and I can actually email this to you as a PDF so that you can get in and actually dig in and read what's in there. But it represents from the moment on the far left side that a patient requires an image and diagnostic imaging, all the way through the whole process until that has been resolved. The individual has the image and it's back at their provider. We had a challenge that this was taking too much time. It was taking a number of weeks, and we wanted to decrease that time closer to the industry average, which is around 1 week or less. And we realized that the cause of that was our own internal coordination. And so we pulled a team together that incorporated all of the departments involved and worked out very carefully the handoffs from one department to the next, making sure that things were effective and efficient, and that we were able to identify areas where we were experiencing friction and delays and eliminate them or resolve them so that we could get those times down. So that initiative has gone very well. However, the biggest obstacle that they face right now, surprisingly, is COVID. So our patient access team is a key component of this, and their ability to reach out and schedule individuals for their diagnostic imaging tests, and also to receive incoming calls to schedule. But there are two things that have happened. One is that we're down 1/3 of our scheduling personnel. We should have 3. We only have 2 of them right now. So we're down a person. And combine that with a high influx of COVID calls for individuals who are looking to schedule COVID swabs and tests. And it's swamping that team and making it very, very difficult for patients to get in to reach that scheduling team, and also making it very difficult for that scheduling team to find time to reach back out beyond returning voicemails, returning those calls and trying to get people scheduled. So we're working through that right now, trying to sort that out and figure out how we're going to remove that obstacle so that people can get through and we can take care of our patients in a timely manner. All right, that's everything I have right now. Any questions?
Any questions? Thank you, Kevin.
You're welcome. Thank you for letting me report out.
Moving on to Mr. Tellis, our CEO.
Well, hello. There isn't much to report. I think we all received a glowing responses in ED and EMS and in medical surgical units.
Those have really been much appreciated. And I thank the team for the workings that they're doing. It's really impressive. I think Brett gave a very good example of how we're being better. We're looking at the phone directory and looking at the phone system. And I think by having that technology to benefit us is really going to be useful. In addition, I think the providers have been asking for a one sign-on. It'll take a badge to sign in and it'll follow them around. I think that's going to be useful. I think that's going to be exciting and that. But the one thing that I do want to say is we are critically short on staffing. I know that we have a pandemic going on, and we still do. We are dedicated to providing this community with quality, safe care. It is important that we have the staff, that we have the quality. You know, if I will tell you, if you don't get vaccinated, if you don't get become safe, and you'll be required to continue to work. It is difficult. It is the state is mandating it, but it is going to be required. It is a tough situation, but anyways, more to come on that, and that's it.
No, I want to ask him where he got that shirt.
Where'd you get your shirt and glasses, Ron?
Oh, stop it. It is a present.
Well, thank God we got a snapshot so I can go into the pulse.
I think I'll show the video from the other day to these folks.
You know, you don't have to do that. You really don't have to.
The context to what Nancy's talking about, last week was Ron's birthday. And so for his birthday, we all ordered shirts, you know, those sequin shirts that like flip up and down. Well, you can get them with faces printed on them now. So the entire hall had a shirt with sequin shirt with his face that was.
I blame Melanie. I
Very
blame
excited.
Melanie. Melanie, you're to blame.
Good for Melanie.
Jake, are we going to need to go into executive session?
We will, but
I just want to ask before we.
Yeah.
But
yeah, we will go into executive session to discuss current or potential litigation.
Okay, so we do have to add on to the agenda here. We need to form a committee for the raising the levy lid.
Yeah, and I can give a brief report on the status of where things are at. I did file, pursuant to the last board's resolution, I filed that with the county elections office and did receive a ballot title back drafted from the prosecuting attorney. I looked at it, it looks fine. So the ballot title is drafted and is ready to be included in the upcoming election. And we have, I also talked to the auditor's office initially. Well, when we submitted the ballot title or proposed ballot title, we did not submit a for or against committee. And she said that we basically can do that up through the end of the month. And so each committee, a for and against committee can have up to 3 people. And
do we have to have an against committee?
We don't have to have either. To the extent that we know people that are against the measure, then we can appoint them. But we, at this point, don't have any knowledge of anybody who would be opposed to the levy lift. So we can't appoint anybody to that. But if there are people that are for it, we can appoint them to the for committee.
Right, but we can only have 3 people on that committee.
Right. And let me get the name, sorry if. Apologize. So the names, let's see, hang on, pull it up. The names that were submitted for the for committee were Jerry Kroon is a community member, and Mr. Wallen, and Mr. Blankenship, and Ms. Phi. So we can only have 3, but those were the names that were submitted for the for committee.
This is just for doing the filing and putting the paperwork together. And I think I talked to Nancy, you're okay with
Yeah.
Kurt and I, and then we have
positive statement.
one person off the board.
Okay. So then, if you are ready to appoint, then it would just be by motion. We don't need a resolution, but by motion to appoint members to serve on that committee.
Just a question, has anybody contacted Jerry to find out if he's
Yes.
willing to serve on this?
Yes.
Thank you.
And I actually just got a text from Aaron saying Jerry is a fantastic guy. He was a great volunteer.
Would somebody like to make a motion?
I move that the committee to form the pro statement for the voters pamphlet be Ron Wallen, Kurt Blankenship, and Jerry Kroon.
Second that.
Any discussion? Greta, did you hear that?
I did, and I'm fine with that. Thank you.
I didn't know, I thought you wanted to be on one more committee, you know?
I wouldn't want to deprive anyone else.
Okay, we have a motion and second. Is all in favor?
Aye.
Opposed? So moved. Thank you. So at this stage, we'll be going into executive session. There won't be any votes, anything taken, so there's no reason to come back in, correct?
Right.
Comments from the community?
The public comment period is limited to the beginning of the meeting like the formers.
Well, in that case, I move to adjourn to executive session.
Do we have a link?
We'll dial you in, Greta.
Okay.
Oh, I guess
You
we
have-
have Ron too. So,
We can patch them both together.
yeah, we'll get you both in.
I'll call you
Okay,
back.
all right.
Thank you.
We are adjourned. Thank you.
5-minute break?
Yep, 5-minute break.
5-minute
All right.